Hello, everyone. This is John McLaughlin. I'd like to welcome you to the webinar, and it's my great pleasure to introduce the speaker today, Dr. Vikki Ho. There are a couple of household things. I think people will be familiar with the chat, the way to address or to log their questions at the end of the call. And I'm sorry. I'm just trying to open this. So the Q&A will follow the presentation. If we don't have the answers to your questions, feel free to log them by emailing to info@canpath.ca. We also welcome you to connect on Twitter and using the handle @WeAreCanPath or LinkedIn as CanPath as well. To start the day two, we'll acknowledge that this work is taking place on the traditional lands of the Mississauga of the New Credit First Nations, Anishinaabe, Wendat, Huron, and Haudenosaunee Indigenous peoples, and we thank them for allowing us to reside as settlers on their traditional territories. This territory was the subject of the Dish with One Spoon Wampum Belt Covenant, an agreement between the Iroquois Confederacy and the Confederacy of the Ojibwe and allied nations to peaceably share and care for the resources around the Great Lakes. We also send our thanks to Mother Earth, the waters, the plants, and the animals for supporting us in all that we need for life. Today, it's my honor to welcome Dr. Vikki Ho. She is an assistant professor at the Department of Social and Preventive Medicine at the School of Public Health at the University of Montreal and a researcher at the Affiliated Hospital Research Center. She is a cancer epidemiologist funded by the Cancer Research Society, which has a program in environment, cancer, and cancer. She has expertise in the role of environmental, lifestyle, occupational factors in cancer etiology, and it's also great to congratulate Vikki on her recent award as a chair in sex and gender sciences by CIHR. So with that, I will happily turn it over to Vikki. Welcome, Dr. Ho.
Thank you, John, for the kind introduction. So I'm very happy here today to have the opportunity to talk about some of our ongoing work in CanPath. So I'm just going to dive right in because I'm trying to cover 2 ongoing studies just to give you a sense of the breadth of information available in this study. So first off, I have no conflicts to declare. So as John mentioned, I am a cancer epidemiologist, and the focus of my research program is on the role of environmental factors in the etiology of cancer. So I think this figure from the Canadian Cancer Statistics really effectively sums up the burden of cancer in Canada, where cancer still remains our leading cause of death in Canada. 1 in 2 Canadians will develop cancer in their lifetime, and 1 in 4 Canadians will die from this disease. So I think what Chris Wild, the former IARC director, said accurately encapsulates the state of cancer research, that it's untenable for us to think we can treat our way out of the cancer problem. That alone will not be a sufficient response. And that's what really motivates my program of research, that prevention in cancer research is still crucial. So to allot more time to discuss the attributes of the CanPath study, I'm just going to dive right into summarizing my motivations for focusing on workplace exposures. First, much of what we know or label as carcinogenic were in fact discovered through the study of exposures in the workplace. And it's advantageous to focus on occupational exposures as more than 60% of the Canadian population work, and many encounters hazards at the workplace. But a focus on occupational hazards doesn't actually limit its application to environmental exposures, given many of the hazards found in the workplace are also present in our general environment. But there are really specific methodological advantages to focusing on occupational exposures. First, workplace exposures are generally occurring at higher levels and are more constant, and so it's easier for exposure assessment, particularly in the context of an epidemiologic study. And a corollary to that is that exposures occurring at higher levels facilitates a larger contrast between exposed versus unexposed groups, and this is what increases the statistical power. And finally, I personally believe that work should be a place that people provide for themselves, their family, and not where people increase their risk of injury or disease for themselves or their family. So identifying and controlling our occupational exposures should remain a public health priority because they're involuntary exposures from the worker's perspective, and most are largely preventable. Just wanted to show other contextual motivations for continuing our pursuit of the occupational causes of cancer. Occupational cancer is still the leading cause of work-related deaths. However, it's still under-recognized and underreported. This graph shows the number of accepted death claims in Canada occurring between 1997 to 2009. The red line represents occupational cancer, while the blue line represents traumatic injuries and disorders. So what you're really seeing here is that in recent years, compensated claims for death from occupational cancer is actually surpassing those of traumatic injuries and disorders, and the increase is increasing steadily. The top 3 industries for deaths claimed from occupational cancer include manufacturing, construction, and the mining sector. And of those occupational cancer death claims, the majority was for mesothelioma and lung cancer. So exposures incurred in the workplace is really still a pertinent area of the study for the primary prevention of cancer. I also wanted to just spend some time talking about the industrial profile in Canada, which is also changing. So it's really important that we continue to assess workplace exposure in the context of cancer etiology. These 2 graphs are showing the occupational profiles of men and women between 1976 to 2019. And what you see here is that in both men and women, as indicated by the yellow line, the service producing sector has been on a steady rise. In men, most of the other sectors have stayed fairly constant. In women, in blue, you see a steady rise in the healthcare and social assistance sector. Layered on top of these changes in occupational profiles, there's also increasing in job mobility. In other words, people are less inclined to stay in the same job. So this further complicates the impact that it can have on cancer risk. Unfortunately, we also have improved occupational hygiene, and so some of the hazards today really differs from those studied in the past. And finally, as the chair in sex and gender science research, I do believe that sex and gender consideration has not been adequately considered in occupational epidemiology. First, there's really a dearth in the literature with regards to female occupational exposures. And second, I'm particularly interested in the biologic underpinnings of potential sex differences that could be further explored. So I'm very lucky to have started my career at this time, whereby there's really been this global push to launch large-scale population-based studies. And one of the main themes of my program of research is really to exploit these databases to inform on environment-cancer relationships. CanPath is really central to my research program, and for those of you who are just joining this webinar to learn more about this study, I'm going to spend a couple of minutes to introduce the platform and then dive more deeply into the occupational data that's available in CanPath. So CanPath is comprised of 7 regional cohorts, but for the purposes of my talk, I'm only going to focus on data available in the 5 cohorts, including the BC Generations Project, Alberta's Tomorrow Project, the Ontario Health Study, Quebec's CANJEM, and the Atlantic Path. In CanPath, more than 300,000 Canadians are followed longitudinally, and this equates to about 1 in every 100 Canadians participating, which is remarkable. CanPath is really envisioned as a research platform for population health researchers. And there's a vast amount of data that was collected for participants ranging from behavioral and lifestyle factors, genetics, family health history, as well as environmental exposures. So really this facilitates an efficient evaluation of the role of these factors in chronic disease. Just going to give you a general overview of the data collection within CanPath. Basically, this consisted of participants coming into an assessment center for physical measurements, as well as to complete a questionnaire. For occupational data, currently all of CanPath participants have self-reported their current job, as well as their longest held job. However, those of you in the audience, if someone's interested in lifetime occupational exposure, there are subsets of participants within CanPath that have reported their occupational histories. For example, I know this has been recently completed in the Ontario Health Study, and this is also done in a subset within Quebec's CANJEM study. So for my ongoing studies, given cancer is a slow-growing disease with a long latency period, we're using information on the longest held job to estimate occupational exposures. And I just wanted to give you a sense of what window of time the longest held job may capture among participants in CanPath. So here I'm taking data from a subsample of participants within CANJEM, whereby participants self-reported both their longest held job and their job history. What we found was that over 60% of participants reported having only ever held one job, which is fantastic. The longest held job essentially represents their entire working life. But amongst those that have held more than one job, the other 39%, the longest held jobs still represent over 60% of their working life. In other words, about 16 years of people's working life. So despite the fact we don't have people's occupational histories, and we only have information on longest held job for everybody in CanPath, we still believe that using the longest held job would capture a meaningful period of exposure. So now that we have information on everyone's longest held job, we're now tasked with how to evaluate occupational exposures. So I just wanted to contrast the two main methods to retrospectively assess occupational exposures, just in case, just to make sure everybody's on the same page. First, we can use an expert assessment approach, and this is when we ask experts to assign occupational exposures based on detailed occupational information. This approach is generally considered the gold standard for retrospectively assessing occupational exposures, but its limitations include it being very long and very costly, and the quality of this approach really depends on the available data, so what you've asked your participants, as well as the expertise of your experts. Another approach is a job exposure matrix, or a GEM. And a GEM is essentially just a fixed set of rules used to associate a list of exposures to any occupational code or job title. One of its main advantages is that it's cheap, it's quick, but its validity really does depend on the quality of the data that was used to create the GEM in the first place. And in general, for all GEMs, it only provides an average estimate of exposures associated with a certain job title. So in our CanPath studies, given the strengths and limits of each approach, we did decide that application of the GEM was most appropriate. So today I'm going to be presenting work from two ongoing projects that links occupational information within CanPath to a job exposure matrix. So I'm going to be talking about two different GEMs. But first, I'm going to spend some time talking about the first one, called the Canadian Job Exposure Matrix, or CanJEM. And this is the GEM that I'm using to estimate exposure to occupational agents. Later in my talk, I'm going to switch gears and talk about another type of occupational exposure, which is physical activity in the workplace, but I'll leave that at a later time. So CanJEM was built by Dr. James Smiatycki and Dr. Lavouille and provides Canadian relevant information on the probability, reliability, intensity, and frequency of exposure to a list of over 250 agents associated with a given job code in a specific time period. CanJEM was built off of data from 4 Canadian case control studies that were conducted in Montreal between the late 70s to the early 2000s. And essentially in these case control studies, experts assessed close to 31,000 unique jobs held by close to 9,000 participants. So I've already alluded back to the fact that the quality of a GEM is really dependent on the data that was used to build it. So given CanJEM is built off of this expert assessed data, we really do believe that CanJEM is unique and of high quality. So for those of you who are less familiar with this tool, I'm just showing you sort of a snapshot of the website. CanJEM was really designed with flexibility in mind. There are 4 different occupational classification systems, 3 different industry classification systems, and basically using these different classification systems, you can create a CanJEM at any resolution for different time periods. And I'd just like to point out that CanJEM is particularly relevant to CanPath and to Canadian research, given that 90% of the recent Canadian working population are covered within CanJEM. So just to bring it to life, CanJEM essentially has three axes. The first one being the job code or the occupational title, the time period, which is completely customizable, and occupational agents, where you can select silica as an example, or you can select all of the available agents in CanJEM. The selection of these three parameters essentially comprises a cell or a cube within CanJEM. For example, here I'm just showing a simple example for a farmer working between the period of 1950 to 1980. And for pesticides, CanJEM estimates the probability of exposure, the median concentration of exposure, as well as the frequency of exposure. So here, if I interpret this cube or this table, the probability of being exposed to pesticide for a farmer that was working between 1950 to 1980 was 80%, at a median level of concentration and a frequency of 2 hours per week. So this was really meant to just be a simple example to show you how CanJEM works. And I've only shown the results here just for farmers in general, but we can refine exposure estimates by specifying subgroups of farmers. For example, I could have another cell like this for fruit farmers versus dairy farmers, and you can imagine that the probability of exposure to pesticides might differ. And we do this by varying the resolution of the different occupational classification system that you choose. So it's really meant to be flexible. So I'm going to start with my first example, which is intended to bring to life the utility of CanJEM. This is an ongoing study that's nested within CanPath, aiming to elucidate the role of occupational exposures and colorectal cancer risk. So for this talk, I'm focusing on two main groups of occupational agents. First, I thought it would be of interest to the audience to show the prevalent occupational exposures experienced by CanPath participants. And second, I will focus in on a specific subclass of agents called endocrine disrupting chemicals, or EDCs. So just some definitions. EDCs are exogenous substances that cause adverse health effects through interference with the endocrine system. EDCs are abundant, they're found everywhere, they're ubiquitous, but there's really still limited scientific knowledge regarding their potential adverse effects on human health. Of course, there's been more and more research showing that EDCs affect fertility, and increasingly there's been some suggestion that EDCs are linked to certain thyroid problems, as well as neurodevelopmental disorders. Increasingly, research has also inferred that the physiologic imbalance caused by EDCs may cause some cancers. So that's sort of one of interest of mine. So I already mentioned that EDCs are ubiquitous, and there are actually over 500 chemicals that are known or suspected EDCs. And from a research perspective, they're very difficult to measure because they're so ubiquitous. Diet, environment, personal care products like cosmetics are all sources of EDCs. But just to bring you back to the motivations for focusing on occupational exposures, the premise of my research program is really based on the fact that if someone is exposed to EDCs at work, they're usually exposed at a level much higher than this baseline environmental level exposure that we all are exposed to. So here I'm just trying to illustrate that with cadmium as an example, where in the general population, cadmium in blood exists between the range of 0.1 to 1 micrograms per liter for non-smokers. We see slightly higher ranges among smokers. However, if I look at an occupationally exposed population, concentrations of cadmium in blood up to 50 micrograms per liter have been reported. So really, the contrast in EDC levels is very high when looking at people who are occupationally exposed versus occupationally unexposed. So the premise of my research program is really to focus in on occupational exposures to further understand whether EDCs actually contribute to cancer etiology. So our ongoing study was funded by CIHR to investigate whether occupational exposure to EDCs is associated with the risk of colorectal cancer. My research chair further extends the study to evaluate EDCs in relation to lung cancer, breast cancer, and prostate cancer. And just for the interest of the audience today, I'm also going to be just showing you our preliminary results extending beyond EDCs only to look at some associations with other prevalent occupational exposures within CanPath. To achieve study objectives, we designed a case cohort study, and I'm going to spend a little bit of time on this design in case the audience is less familiar with this design. So essentially, this comprises of our case group, where we identified close to 1,100 incident cases of colorectal cancer. This is occurring within CanPath baseline, the inception of CanPath, to about 2016. And I say about 2016 just because it really depends on when the provincial registries were linked to each of the regional cohorts participating in CanPath, so it was around 2016. For comparison, we established a comparison group called the sub-cohort, which of close to about 5,000 individuals, and this is essentially just a random sample of the CanPath cohort at baseline. We sampled approximately 4 sub-cohort members for every colorectal cancer case, and this is why you have a 1-to-4 ratio here. And for both cases and sub-cohort members, at baseline, we excluded all participants that had a history of cancer other than non-melanoma skin cancer, as well as those with missing information pertaining to their longest held job, given this is our main exposure of interest. And again, just to highlight the advantages of a case cohort design, basically the sub-cohort is representative of the full cohort, given it's just a random sample. And one of its main advantages is that the sub-cohort can be used as a comparison group for multiple outcomes. So this is why this facilitates us using the sub-cohort in relation to lung cancer risk, breast cancer risk, prostate cancer. So it's really efficient in this respect. So given that the sub-cohort is a random sample of the underlying CanPath population, I thought it'd be interesting to just show you some descriptive statistics. I know this is a busy slide, but I'm just going to highlight some trends. What we see here is that the majority of CanPath participants are white, have a post-secondary education, are at a high income bracket, and self-report to have never smoked. Here is an overview of the top 5 jobs that CanPath participants hold. Here I show the trends, the top 5 jobs by cohort: Ontario, Quebec, Alberta, Atlantic provinces, and BC, as well as an overall. And I'd just like to note that the overall excludes Ontario Health Study at the moment. So just in terms of drawing your eye to general patterns, what we're seeing here are that clerical jobs are the predominant occupation in CanPath, followed by teachers as well as professional nurses. We do see some cohort-specific characteristics, like in Alberta, we see general farmer being one of the top 5 occupations. All the participants that were selected to be in our case cohort study have had job codes assigned to their longest held job. In the interest of time, I'm not going to go into the details of job coding, but I cannot stress enough the importance of doing this well, given assigning a job code to someone's open text job title is really the key that you use to link to a GEM. So it's really critical that it's done accurately. So for our participants, we coded according to 4 different classification systems, 2 occupational and 2 industrial. And for today, I'll just be showing the results linking CANJEM using the International Standard Classification of Occupation 1968, or the ISCO classification. And I've already mentioned to you that CANJEM is very flexible, and choosing different parameters essentially creates a different CANJEM. So for this analysis, we basically included all periods available in CANJEM and all the agents available in CANJEM. This resolution-wise resulted in almost 180,000 cells, consisting of almost 700 different ISCO codes. So today I'm going to be presenting just preliminary results of our CanPath analysis. And so for the remainder of this talk, I'm just going to be excluding Ontario Health Study just because this analysis is still ongoing. So when we applied CanJEM to CanPath by linking via the ISCO code, what we found was that we were able to link about 80% of job at the finest resolution of the ISCO classification. This is the 5-digit represents the most specific. However, I do want to point out, unfortunately, in CANJEM, or the Quebec cohort, we had a fairly large proportion of jobs that were not codable or linkable. And this is just because CANJEM used a different question in assessing longest held job. It was not open text, it was a series of options, and this is probably what led to the difficulty in job coding. So I'm gonna spend time on this slide just to make sure you fully understand it. It's also an inherent characteristic with using a GEM in CanJEM. So when we use CanJEM, we have to differentiate exposed versus unexposed jobs. And how do we do that? So in CanJEM, we can use the probability of exposure, which is really just percentage of jobs considered as exposed within a cell in CanJEM. So here I'm just giving you a very simple example. Imagine I'm trying to estimate the exposure of gas welders to agent X in CanJEM. There were 8 exposed jobs, 8 exposed gas welders over a total of 10 gas welders. Then the probability of exposure is just 8 divided by 10, or 80%. Using the probability of exposure, we explored 2 different metrics to define occupational exposures. First, a binary ever-never metric that's based on a cutoff of 25%. So those that had over 25% probability of exposure were considered ever exposed, and those with less than 25 was considered never exposed. We also tried to refine the never exposed category by creating this potentially exposed category. And we further explored another metric, which we call the substantial metric. And this is essentially just focusing on people that are ever exposed, defined based on this threshold of 25%, but whom have higher than median concentration of exposure. In other words, they're exposed at a higher concentration of exposure. So I'm just going to present sort of our overall statistical approach for the 2 studies. So we used a weighted Cox regression model to estimate hazards ratios and 95% confidence intervals for colorectal cancer risk associated with occupational exposures. Now, weighting is important in a case cohort study because we want to approximate the estimates that would be obtained if we were able to analyze the full CanPath cohort. So because we're looking at multiple occupational exposures, we created separate models, adjusting for cohort as a random effects parameter. In our minimally adjusted model, we adjusted for agent sex, and in our fully adjusted model, we additionally controlled for the traditional risk factors for colorectal cancer. So here is a list of the 19 EDCs that are available in CanJEM. I just wanted to show you that they range from broad categories of chemicals like herbicides, aluminum compounds, to those that are specific, like copper and toluene. And those indicated with the star are agents that have at least 5% exposure prevalence amongst CanPath participants. So in the future, with the addition of Ontario Health Study, we hope to be analyzing agent-specific models. After linking CanJEM to CanPath, the top 5 jobs exposed to EDCs were farm workers, those in retail trade, those in long distance transport, and their associated EDC is just listed here to be copper and lead. So here are the results considering exposure to any of the 19 EDCs in both minimally and fully adjusted models. In the ever-never parameterization, what you're seeing here is that those ever exposed to any of the EDCs were associated with a higher risk of colorectal cancer. However, I would urge you to interpret these findings with caution since we're still analyzing OHS, and OHS represents almost 50% of the CanPath population. So I think there's going to be a lot more work to be done here. And also, we don't see the same trends as expected with the substantial exposure parameterization. I initially hypothesized that those who are ever exposed at a higher than medium level of concentration would be where we expect the highest risk. we don't see those trends repeated. So I think it's suggestive, but it still needs more work. So again, moving beyond EDCs, I just wanted to showcase the top 5 most prevalent agents in CanPath. And again, I'm just excluding OHS here for simplicity. In all of CanPath, what we see here is that pH from any source, organic solvents, as well as engine emissions were among the top 5 agents that CanPath participants were exposed to. This was fairly similar across cohorts, though we do see some different agents peeping up in the different cohorts. And here are just the preliminary results for pH from any source in relation to colorectal cancer risk. What we're seeing in the minimally adjusted model is that ever exposure to any pHs was associated with a higher risk of developing colorectal cancer. However, this is greatly attenuated when we fully adjust for all the traditional risk factors. Here are the preliminary results for organic solvents and colorectal cancer risk, but I would say the results here are even less consistent than that of the pHs, so really indicative of probably null associations. So today, the intention of my talk was really just to showcase to you the continued value in considering occupational exposures in the context of cancer. But at this point, I'm really going to switch gears and still focusing on exposure in the workplace, but in place of chemical exposure, I'm going to be looking at occupational physical activity in relation to lung cancer. So given we've had our minds on agents and chemicals, I just wanted to start off with some definitions to reorient you. So by definition, physical activity is really just any bodily movement produced by skeletal muscles that results in energy expenditure. So it may seem like a very intuitive or a simple behavior since we all do some sort of physical activity in our everyday lives. However, it's these very simple tasks that we perform every day that contributes to our overall level of activity. So in an epidemiologic study, it's actually an incredibly complex behavior that's hard to capture. Now, researchers have used either all or a combination of the different domains to measure physical activity. These include the type of activity, the intensity of activity, how frequent we perform these activities, and the duration in which we perform these activities. And a common unit to quantify intensity of activities is via a metabolic equivalent of task, or a MET value. The MET value is really just the ratio of the metabolic rate when you do a specific activity divided by the reference metabolic rate. So MET of 1 is your resting metabolic rate when you're quietly sitting. And MET of 2 would be 2 times that energy expenditure. And this would be equating to walking at a slow pace. So I want to justify a focus on occupational physical activity. This graph is from a descriptive analysis of the Alberta's Tomorrow Project and presents the number of hours per day that men and women spend in the different types of activity by activity level. I know it's a complicated figure to present near the end of my talk, so I'm just going to draw your eye to the gold box and focus in only on the active and the very active groups. And here I'm just going to highlight that the red brackets indicate the contribution of occupational physical activity. So what we're seeing in comparing these bar graphs is that for men and women, occupational physical activity is the largest contributor to the hours per day spent in activity. And it's particularly striking in the active and very active group. I wanted to quickly summarize the evidence on occupational physical activity and lung cancer. So here are 2 forest plots obtained from a recent meta-analysis looking at occupational physical activity and lung cancer risks separately in men and women. What we're seeing here is that in men, the risk estimates appear above the null, indicating a positive association. In other words, higher occupational physical activity leads to higher lung cancer risk, while in women, most results are null. However, I do want to point out that's one of the main limitations of previous research really included a crude measurement of occupational physical activity. most of the time they ask participants to self-report whether they considered their job to be sedentary, active, or very active. So in Montreal, we performed a series of case control studies where we devised an expert assessment approach to assess occupational physical activity. And here I'm just going to walk you through it. This is the beginning of our second gem. So based on information collected in interviews pertaining to the main task that a person reports across all jobs in their working life, we essentially had an industrial hygienist and an exercise physiologist sit together and assign a MET value to each of the major tasks. So here's an example. A person could have been a logger and a carpenter in their working life. And as a logger, he spent his day doing two main tasks, felling trees and axe chopping very, very fast. So using the compendium of physical activity as a reference, our experts assigned a MET value of 12 to felling trees and 9 to chopping very fast. And because we've done this through a series of case control studies, we've now amassed this database of occupational physical activity in which we have the median level of activity in METs available again in this ISCO classification. So we've not officially made this database into a gem, but it functions in exactly the same way in that we're linking jobs via a job code to estimate occupational physical activity. So in another ongoing CanPath study, we're using this physical activity gem to estimate occupational physical activity levels and assess whether it's related to lung cancer risk. So I'm just going to pass through this slide quickly because you've seen it before, but it's really intended to just illustrate the beauty of the case control design. Because here I'm able to use the same subcohort that I presented to you previously, and all we're doing is changing our case group. So instead of looking at colorectal cancers, I'm now looking at lung cancer. I do want to point out that the ends are quite different, and this is because here I'm excluding Ontario for now, as well because our physical activity gem is actually less exhaustive in terms of coverage than CANJEM. There were actually a lot of jobs that were not linkable. So after linking our occupational physical activity gem to our CanPath participants, we categorize a participant's longest held job into high, medium, low rates of activity. So here I'm just showing you sort of the descriptive of for men with jobs in the high occupational physical activity level, their MET ranged from 2.16 to that of 6.5. And the top 3 jobs amongst CanPath participants that were in this high physical activity category were retail trail salesmen, other service workers, construction workers. In women, we found a slightly narrower MET range for the high levels. These were sex-specific, defined sex-specifically. This is why the ranges differ. But basically in the high occupational exposure category, the MET ranged from 2 to 4.8. And the top 3 jobs contributing to this category were medical doctors or assistants, teachers, as well as the same retail trade salesmen that we saw for men. So we use the same statistical approach as before, as what I presented to you for colorectal cancer. And here I'm just showing you the fully adjusted results in separate sex-specific models. We also adjusted for different confounders that were identified using direct statistical graphs. And in general, among men, what we're seeing is that increasing or higher levels of occupational activity is actually associated with a higher risk of lung cancer. While in women, a very different trend is seen. It's actually J-shaped, where we're actually seeing some protection in the medium level category of occupational physical activity. So I would like to note that in the models for men, we adjust for occupational lung carcinogen exposure. And this is because we believe jobs that are physically demanding usually have some co-exposure to lung carcinogen. So we essentially adjusted for this. We didn't do this for women only because there were very few women that were exposed to lung carcinogens at work. So like the results for the colorectal cancer, I would interpret these results with caution given the extremely large confidence intervals that we're observing. And also, I didn't have time to go into this, but basically there were cohort-specific effects. In other words, the physical activity lung cancer association appeared to differ by cohort. So in future analysis, we will be using a meta-analytic approach to try to pool the results over studies to reflect this heterogeneity. So I'm going to end the talk with our future directions. I've already alluded to the parallel analyses that are currently underway with OHS, as well as exploring additional occupational exposures in CanJEM. I've already shown you some of the top agents. When we are able to add OHS data, we'll have a lot more power to look down the list of prevalent agents and explore associations with the various cancers. And lastly, we are actually currently improving CanJEM, and the idea is to facilitate sex-specific estimation of occupational exposures, so developing like a CanJEM female. So future analysis will consider linking this new CanJEM to CanPath, just to evaluate how robust our findings are when considering sex or gendered exposures. So just to end off, I would, of course, like to thank CanPath participants, without whom this platform wouldn't be available, my research program wouldn't be available. And so a big thank you to them. I'd also like to acknowledge my research program within CanPath is supported by CIHR, all my friends and colleagues and mentors who really contributed to helping me start my research program, as well as my salary support from the Cancer Research Society. And I just have a final plug that if you liked my talk and are interested in cancer epidemiology, we have many opportunities here in Montreal, so please don't hesitate to apply. And that's it. I'm happy to open the floor to discussion or questions.
Thank you, Vikki. What a tremendous amount of work and presentation. So this is John McLaughlin speaking again, and I'll serve to sort of moderate the Q&A session. There are a couple of, I welcome anyone to post some questions under the Q&A, and we'll start with one from Suzanne saying, I'm wondering if the option of route of exposure is included in factor options. I believe that might relate to your the GEM development. So the route of exposure is included in the factors that are considered?
So it's a complicated answer. In the case control studies, it depends. They did consider dermal versus inhalation routes of exposure, but I think this changed over time in the different case control studies. So I guess I would say yes. However, when they put this together within the GEM, this is not an option that's available within CanJEM for you to tease out dermal versus inhaled exposures.
Thank you. Another question from Val. Val Wolf has asked, wondering about the timeline for the Ontario data, and I'm interested in this, but would you come back for another webinar when that's been completed?
With pleasure. So we have Ontario data. So we have Ontario data, and the analysis is ongoing, I guess, I presume in a year. I'll be happy to come back in a year to do an update.
Okay, thank you. Another has, Miriam has commended you for an interesting presentation. Could you please provide more information about the weighted Cox regression? What was the follow-up time among cases as well as the subcohort?
This is a great question. This is a great question. So it's because the longest held job was used. And so there's sort of two parts to this answer, because logistically, we didn't have the age at which a person started their longest held job or the end date for all of the cohorts. So essentially, we used our time zero as baseline. So depending on which of the cohorts we're talking about, it would be around 2009, and then the at-risk time would be until an event or censorship. But it's a great question, because this is why I still talk about this as preliminary analysis, given that time is not really appropriately taken into consideration, given we don't have all of this information. Perhaps we would explore a logistic regression approach to assessing, to estimating relative risks.
Thank you. Another question from Richard Stern. What data did you use to adjust for smoking in the lung cancer study, given that smokers are nearly always underreport their smoking history? That's more of a question about the quality of the CanPath data than your own occupational data, but how would you describe that?
So in CanPath, I mean, it's true, underreporting is always an issue. In CanPath, they've collected information on smoking status, smoking duration, number of cigarettes smoked on average. So we basically created like a pack years variable to control for this, but it's a good question, it's a good point.
If I can add to your response, which is excellent, but also for people to realize that the beauty of the cohort design actually really does manage to account for, remove the recall bias that occurs in many case control, or in your situation, case cohort designs, so that the biasing effect within a cohort study where the smoking data was collected long before the cancers occurred. Would that be a fair statement? Or are you using prevalent cases on this?
No, incident cases.
Correct. See how the, so there's a real strength of, as you put your paper together, that can be recognized as a strength. It's a very good point. There may be other questions arising, but I could add a question because very interesting results near the end about a pattern going one direction with men and another direction with women. So, and also I really do admire your approach to recognizing occupational physical activity is an important occupational exposure. So with tremendous gender differences potentially. Given that the actual occupations that go into the men's categories versus the women's categories are so different, is it possible that there might be some other exposure relevant differences that would give rise to, in particular, I'm thinking of the male pattern. Any comment on that?
I mean, absolutely, John, you hit the nail on the head. I mean, it's incredibly hard to tease out occupational physical activity from occupational exposures, because we do believe that physically demanding jobs are generally performed in hazardous settings. And so the best we can do is try to control for these exposures, which is why I mentioned we had tried to at least control for lung carcinogen exposure. But I mean, this was, but there might be other occupational exposures that we're not accounting for. So I completely agree. The large increase in risk is probably not just due to activity levels, but really the co-exposure of being active in a hazardous setting.
Thank you. I don't, okay, are there other questions on the queue here? I'll just scroll down. What is the rationale for different outcomes, case cohort, to share the same sub-cohort for the comparison? So you touched on that briefly, but can you further describe that sub-cohort design as essentially the control for your case?
Yeah, so the advantage is really, in contrast to doing 4 nested case control study, I could do 1 case cohort studies with multiple case groups. And the main reasons for doing this is really because job coding is really expensive. So having 1 control group, 1 sub cohort for comparison really facilitates us to add cancers, add outcomes. So I'm not just thinking about sort of my own personal interest. When we give the data back to CanPath, you could use the sub-cohort to look in relation to other chronic diseases.
Thank you. And again, the approach to your design where you've actually been able to increase power by having a larger number of controls, i.e. through the sub-cohort, is also a strength for this type of use of a very large cohort. I should acknowledge and thank Jason Zhu for submitting that last question. Sue Street has asked the question, Great to see CanJEM undertaking a sex and gender-based analysis of the data. It's hugely important, especially when considering the gendered nature of occupations and differential risks exposures being experienced by women and men. Are you examining any of the rare cancers? She's asked about thymomas, plasma cell myeloma in your analyses.
So for me personally, I am not. I think Arlette would like to comment. I guess for me, I think rare cancers are extremely important and interesting. And the only issue is I don't know the number of accumulated cases within CanPath, since CanPath is still a relatively young cohort. So I would presume we would probably still have to wait before enough incident cases of these cancers actually occur.
Yeah. And again, this goes right back to, it's a good question that was raised. It does relate to the design of CanPath. You know, one reason for it being proposed and funded as Canada's largest population-wide cohort study is to allow work exactly like what you've led, Vikki, and that is to study the causes of incident cancer. Now, of course, in the first round of analyses, which you're just doing now, the numbers of cases in the statistical power, by definition, we knew would only be there for lung cancer, colorectal cancer, breast cancer. But over time, it will become possible with longer follow-up, just as you've said, it will be possible to look at rare cancers. And then finally, rare cancer consortia are actually the reason why international consortia are established. And that's where people like yourself and your colleagues can actually work with other cohorts internationally to really look at the causes of those very, very rare cancers that need larger studies even more. A question from Kimberly O'Connell. Curious about your choice of ISCO 1968. Are you considering more up-to-date or updated occupational codes up to 2012, for example?
Yes, absolutely. I mean, the reasons why we coded according to different classification system was so that we could repeat these analyses across the different classification systems to ensure that our findings are robust. So it's a very good point.
Yep. There's a personal invitation for you from the Occupational Disease Action Planning Group. So I'm sure you'll have other people who would love to talk to you more, so that can follow this. Do you have a timeline for the completion of CanJEM Female? We are working on something similar at CAREX Canada.
Hello, Cheryl. And probably next year, actually. So all the data is, all the expert assessments have been completed. Right now, we are incorporating it into CanJEM. The report should be written by next year. So yeah, the intention is next year. So why don't we touch base like mid-year 2021?
Okay. Let's see. Which question? So Cheryl's acknowledging that. There might be, Marina has asked, there might be some value in distinguishing physical labor type of job associated from jobs associated with higher physical activities, which are not in the so-called physical labor category. In other words, there might be different types of physical activity. This could not be measured by METs. Can you comment on that? It's from Marina.
You know, I'll have to actually talk about the case control study that sort of led to this data of the physical activity gem, because we tried to do this. Essentially, when we used the expert assessment approach, we had experts assign METs, but also assign a dirtiness index in terms of whether you think it is being conducted in a hazardous setting. However, when we adjusted for this and we looked into this, we didn't really see anything. But that doesn't mean that it can't happen. But I guess this is the best we can do for now. But I agree, you know, maybe beyond replicating studies on occupational physical activity and lung cancer risk, we should be trying to more strategically devise ways to better assess occupational physical activity, to tease out, is it occupational physical activity or is it co-exposures? to really inform on whether it is a risk factor or actually a protective factor.
Sure. Thank you very much. Kimberly has asked sort of a follow-on to the previous answer that you had given, asking to, wondering if occupational codes from 1968 would affect gender differences or lack of exposed female occupations. So that's related to the transition over the occupational classification itself, and whether the result, is there any way that the results that you've seen with gender specific patterns being, let's say, opposed, whether there could be anything there?
Yeah, that's a good question. In all honesty, I don't know whether occupational codes and the transition could affect gender differences. I'm just trying to think of how we can look at this beyond just replicating with other classification systems, but it's a very good point. It's possible, I guess.
This is, given the purpose of today's seminar, I think you've actually demonstrated the possibility of this type of work, and a number of points that have been raised in these questions could be considerations in your paper that will come out when the work is complete. There's not another question on the Q&A right now, so I would like to ask one, which is, one of the strengths and advantages of this cohort, CanPath, is the inclusion of a biobank. So in the world of occupational exposures to such things as endocrine disruptors or physical activity, have you any, and this isn't necessarily work that you must do, but maybe some of the listeners could be involved in this type of thing, but are there biomarkers of exposures that would help disentangle the complex patterns that you've presented and answer some of the questions that people have raised? Any thoughts on the potential utility for these exposures that you're studying to be better understood using biomarkers, which, by the way, CanPath has been designed to foster analyses of?
It's such a good question, John. We in fact actually have a study that we're submitting, and it's not to plug another cohort, but the UK Biobank is very similar to CanPath, and they have a biobank as well with lots of biomarkers measured. So for an example, a very interesting parallel study that we're trying to conduct is to look at estimating occupational exposures to EDCs using CANJEM, and whether this actually leads to differences in sex hormone levels. So I see great value in furthering this kind of work. We're using UK Biobank only because this is already available, but I totally envisage doing this within CanPath. Other markers like DNA methylation is complete. We already have an ongoing study within CANJEM looking at occupational exposures and the impact on DNA methylation. So I think it's perfect that CanPath exists and is this amazing resource for us to first look at maybe the large exposure outcome associations, but then afterwards to tease out into these more smaller mechanistic studies to really inform on exactly how does EDCs increase cancer risk.
Thank you, Vikki. From another Vikki, or Victoria Kirsch, there's one final question, and then I'll have to wrap up due to the time limit. So Vikki Kirsch has asked the question, did you exclude those with a history of cancer, either any cancer or the specific ones that have been considered colorectal or lung?
We did. At baseline, all participants have had to have no previous history of cancer, except non-melanoma skin cancer.
Okay, so that's excluding those with a previous history of any cancer, which would, again, I think, strengthen the validity of your study, while indeed it also reduced your power, but you still have huge numbers of cases, and so that's to be commended. So I'll just try to wrap things up, but with all of the participants, the very last slide that Dr. Ho has presented actually does explain where people can go to access CanPath data. go to the website for more information, and that particular portal is the place where data access possibilities and actual applications can be launched. And please, with all well over 100 people observing your presentation today, Vikki, we thank you very much for presenting today, but especially for doing this important work. I think it's remarkable to see what you've accomplished, and I am sure we will all look forward to seeing your final presentations and papers on this. So congratulations.
Thank you so much, John.
Okay, thank you all. I guess we can sign off and talk again. Bye-bye.